A very good evening to everyone who just joined us from Kopi Vans. This is your host, Vancia. This is not a signature dance, but I just decided to do it on a last minute. Life is all about dancing. All right, so that's not the topic today. And today our topic is, let me just pull up the banner. That's right, why you will need lung surgery. And that's why, and today we are going to talk a lot of stuff that is pertaining to the respiratory system, and not only just the system itself and what can actually cause the other side, which is of course when we are looking at cancers and so forth. But like I said, every Wednesday we are back at 9 p.m. All right, I know the last two Kopi with session was started at almost about 9:30, but now we change it to 9 p.m. as well. It's every Wednesday only at Kopi Events. Okay, as usual, before we start on, so there's my cup and cheers. I hope my guest speaker also have his coffee in his hand. So later we check whether he's having the coffee or not. Right, cheers. Okay, so without any ado, I'm going to bring up my guest speaker. And also, it's a great person. And I know he's very extremely busy. And he does a lot of amazing things. I often say that many times that nurses and doctors are the angels that been sent down to planet Earth to take care of us as a humans, right? This gentleman is none other than Mr. Harish Mithiran. He's a consultant thoracic surgeon, Department of Cardiac, Thoracic, and Vascular Surgery, and he is from National University of Hospital. So let's invite Dr. Harish. Hello,
Hey,
Dr.
Vance,
Harish.
how are you?
I am good, sir. How about you?
Great. Yeah, thank you for having me on your show.
Thank you, sir. I know this wasn't as expected, but are you holding on to your coffee cup?
I got water, but I need to
All
get some
right.
more coffee then.
Thank you so much for joining me in Kopi Events, Doctor. I know we talked about this about 2 months back, and I know you have a very hectic schedule. And how is it going on? I mean, how has it been for you over the past 1 2 months, Doctor?
Well, it's been, I would say great, but it's been busy. We've got our cycles. Some weeks are really, really strenuous and just on the ball nonstop. And some weeks we have a little bit of a down session or coming down level where you relax a little bit. But overall, it's just an ongoing process. Monday to Friday, sometimes Saturday, Sunday. You're in the operating theater, you're doing surgery, and well, it's just like that, I guess.
All right, all right. So I'm sure you're keeping well, also, Doctor.
Yes, I am, and good. I want to say good evening to all your audience out there too. Um, you know, and I hope you guys enjoy this talk today.
Thank you, Doctor. But I know you have some PowerPoint slides to show with us, and we have certain topics to go along. But Doctor, can I just ask you? We heard about endocrinologists, we heard about cardiologists, orthopedic, but consultant thoracic surgeon. Um,
Yeah, I mean they
I mean,
always
I
say
mean,
thoracic, Jurassic. Well, what's that?
and also thoracic is often associated with the spine, the thoracic, the lumbar. Um, so
Exactly. You're
So,
absolutely
so
right.
maybe you want to talk a little bit about that, Doctor. I mean, how that name came by,
So,
and
so thoracic basically refers to the thorax, which is the chest. All right. So generally, in at least in Singapore and the Commonwealth countries, to become a thoracic surgeon, you actually train as what we call a cardiothoracic surgeon. So you're a heart and lung surgeon. So you do everything in the chest, which is everything under the skin, the ribs, the lungs, the windpipe, and also the heart. But eventually, with time, as lung surgery and heart surgery became more and more focused, so the heart surgeons and the lung surgeons, we trained as one group, but eventually we start to subspecialize. And for me, I decided to just focus on what we call the thorax or the lungs. So I do everything in the chest but the heart. And there's another group like my colleagues, they just focus on the heart and they are cardiac surgeons.
so could we say that thoracic surgeons are both in the respiratory system, of course, the lungs, the heart, and any more other involvement, Doctor? I know
Yeah,
it's
so
more
we
fine.
I will put up a slide after this, so maybe and then everyone can see.
Sure.
So it'll be
Thank you, Doctor.
we can. I always like to show things with photographs, so that's always better.
Let's do that. Let's do that. So,
Yes.
ready, Doctor? I mean, for your presentation, please. Thank you.
Okay. Let's hope the share screen thing works.
Right.
And here we go. Can you guys see it?
Yeah, we go. I pull it out over. That'd be great,
Okay,
doctor.
great.
All yours.
So my topic today basically is why you would need lung surgery. So a lot of times people say, "Oh my God, surgery on the lungs. Why? What? What's going on, right?" Um, so basically, I'm a thoracic surgeon, like what Van said. So you can see I put a diagram up here, a cartoon over here that shows you what the thorax actually encompasses of. So we're talking about ribs. So anybody who gets fractured ribs and that needs surgery for a really bad broken rib, we fix that. We focus on the lungs, of course, the main area here, which is we deal with a lot of cancers, a lot of infections within there. We deal with the windpipe or the trachea, and we deal with problems in the diaphragm, the area that separates basically the abdomen or the intestines from our chest. And if you do a side view, say there's an anatomical dissection, and we unfortunately we look at this from the side, you can see the front here is the breastbone over here. The heart
Mm-hmm.
is sitting in the center, and then you got the spine. So that's the thoracic spine we were referring to. So that's the part of the spine that's in the chest. It's called the thoracic spine.
Okay.
And so we deal with things that are like behind the breastbone over here. You can see there's
Mm-hmm.
something called a thymus gland. So unfortunately, things can grow over there too. Things can grow behind the heart and around the heart, and that's what thoracic surgery. So that's what we do. But my topic today basically is to focus on lung surgery per se, not anything else, but just what one portion of what we do is lung surgery, and that's where we actually see a lot of patients coming in that require it. And so what is a patient's journey through this to coming and doing lung surgeries, that we a lot of times many people do an x-ray, and an x-ray is a very important what we call a screening tool, and you do
Mm-hmm.
this either on your normal medical checkup, or you do it when you do an employment checkup, or say you have a cough, the doctor, your general practitioner, your GP says let's get an x-ray to make sure there's nothing else there, and they do an x-ray, and god forbid, they find like a small growth or a nodule. You can see here. Can you tell? I put a box over here. Can you see that, Vance?
Yes, it's something
Yeah,
like a shaded, with very light color.
exactly. So this is a very clear-cut X-ray where you get a round ball kind of a
Mm-hmm.
structure there. But just looking at an X-ray like this and you see a ball, really you can't tell what it actually is. I always have my
Mm-hmm.
standard story I tell my patients. It's the X-ray and CT scans are like photographs. So you take a photograph, say you take a photograph of my phone, and then you say, okay, this is an iPhone, and then or someone will say, no, that's a Samsung, and you say why, and then you say, okay, the size and the shape and stuff, so therefore it looks like a Samsung or it looks like a Apple, but you really, really only know the answer when you go inside, open up, and you see the chip inside, right? So
Right.
to go and further look at it, we have to do something called a CT scan. So that's why when you say, "Oh, I do an X-ray," why couldn't they tell anything? Because sometimes X-rays can't pick up small, small nodules. So we do a
Mm-hmm.
CT scan for the patient, and this is a scan, what we call a cross section. So the patient's lying down. The front here is your breastbone up here. These are different cuts, and then
Okay.
the heart is in the center over here. We have our lungs on the side here. And I don't know if you can pick up, but you can see here there's like a whitish, like a ground
Mm-hmm.
glass stain kind of an appearance in the lung. And
Yeah.
these kind of scans are things that we get worried about. And if you look on the other CT scan right over here, you can see the bigger balls over here,
Yeah.
like round what we call nodules
Okay.
in the lung. And these are things that are concerning. So when these patients they do an X-ray, and then the GP or even they see a specialist and they say, look, we need to do a CT scan. We actually want to see a better image of that lesion or that nodule. That's why
Mm-hmm.
CT scans are very, very important um, to us surgeons. So when we do that CT scan and we find out, okay, this lung lesion looks very suspicious, then we want to do something about it. Either we want to take a biopsy or we want to go and remove the lung lesion. So, what are the other
Okay.
common lung surgeries? So, like I mentioned to you, so the first thing, a lot of our patients are actually patients who have cancer, and we need to
Okay.
remove that. But there are other other indications of diseases in the lung that we actually perform surgery for. And there are some of these
Mm-hmm.
lesions they look like cancer, but they end up not being cancer. But because they reach a certain size, they still need to be
Mm-hmm.
removed. And then there's something called pneumothorax. And pneumothorax is basically it happens in people who smoke, smokers, or even
Mm-hmm.
young boys and girls who are the classical description is thin, thin, tall, young males because
Okay.
what happens is the lining of the lung um, forms a small bubble, and that bubble bursts. So when the bubble bursts, the sealant of the lung gets it opens up, and whenever you breathe, air leaks out of the lung, and that causes
Okay.
the lung to collapse. So our job is to go in there to find that leaking part, like the tire that's
Mm-hmm.
leaking, and plug the hole.
Mm-hmm.
And then the other big thing we actually deal with is infection in the lung, and but not in the lung per se, because that's pneumonia, and that you treat with antibiotics. What we do is if the infection spreads outside the lung into the space around the lung, and that space then becomes filled with pus or infection fluid, and then we have to go in there and clean it up and do a washout basically.
Mhm. Mm. Doctor,
So when
can
you
I just
yeah
hold you here for a while? Sorry. When you describe all these little fine things, right? You go there and clear up this, do this. It sounds like you're some kind of like a robotic, like a specialist, or some kind of like a technician or a specialist who's going in and working on some kind of engine. It's quite similar, isn't it? Engines we can just change it. Human bodies also nowadays can seem to, but you seems to be like
right.
understands, and these are years and years of experiences and research. Is it something that it's natural? You look at it and this is an issue.
Well, let me take you to a little bit back of the history. Um,
Okay.
we when we become surgeons, we graduate from the Royal College of Surgeons of either Edinburgh in UK or England or one of those.
Yeah.
And actually, doctors, you graduate, you get your MBBS, and you become a doctor. Then
Yeah.
once you become a surgeon, you get the FRCS title. You actually become Mister again.
Oh,
Yeah, that's
okay.
the title change. And the reason is because of this is hundreds of years ago, doctors said do no harm, which means don't operate, don't cause any harm, don't cause any bleeding. And so
Hmm.
the College of Barbers used to
Hmm.
perform all these lumps and bump operations. So they were barbers before. And eventually, with
Okay.
time, they integrated with the college and became surgeons.
Wow.
So if you come from the Commonwealth, like the UK and stuff, all the surgeons are called Mister. It's not adopted very much in Singapore, but like in Malaysia and the UK, most countries they call them Mister. So yeah,
I
you're right.
say
We
something new.
we are, I think we are highly skilled medical doctors who perform in surgery to remove disease part of the lung. So last time you say do no harm. Now we're doing no harm, but we are trying to help to remove that part of whichever part that's not right in your body.
Amazing, doctor. Amazing. I mean, like I said before the show started, that often, right, nurses and doctors are like the angels. You all should be having that. The wings. It's just that it's hidden behind your white coat itself. Because it's amazing. How things has evolved, and I'm sure after your presentation, we're still going to talk on all these little areas. But sorry for the disturbances. So please go ahead, doctor, with your PowerPoint, and
No,
then
no, no.
we will
It's
catch up.
great, Vance. I love this conversation. It's awesome.
Thank you.
So coming back to, I'm just going to focus on lung surgery. So
Okay.
when a patient comes and says you need lung surgery, so we have a pair of lungs. We have our right lung and we have the left lung. And the
Yeah.
right lung basically is divided into three parts called the upper lobe, the middle lobe, and the lower lobe. And the left side has only two parts called the upper lobe and the lower lobe. The reason people say is because the heart goes more on the left
Mhm.
side, so therefore the evolution has made into just two lobes instead.
Mhm.
So what happens is that when we do lung surgery, if say there's a growth in the lung, we can just
Mhm.
do something called a wedge resection, where we just remove a really small portion of the lung and take it out.
Okay.
We can do what we call a segmentectomy, where we dissect each specific blood vessels to a certain segment of the lung and remove
Okay.
that. Or we can remove like the whole lobe, like in cancers, any cancer that is larger than 1.5 or 2 centimeters, then we generally have to take out. Remember, I told you about the three parts on the right and two on the left. We have to take out the whole
Yeah.
section of it, the lobe out, because cancer
Mhm.
can spread within the lobe. And
Okay.
pneumonectomy is not done very often nowadays. It used to be a surgery it's still done today, but not as often. It used to be done for really large cancers, really big tumors that and they didn't have chemotherapy then, and we needed to resect it. Or the tumor is so big that we still can control the disease. So then we decide to remove the whole lung, but it's not done very much nowadays. We do a lot of
Mhm.
lung preserving operations. What we try to do nowadays.
Okay.
And how do we get to the lung? So basically, Again, back in the days, we used to make a big cut, and you can see here literally from the
Mhm.
back all the way to the front to access the chest and get in there. But with time, with evolution, I think everyone's talking about keyhole surgery or laparoscopic surgery. When you say laparoscopic, you refer to surgery in the abdomen. So we do what we call
Mhm.
thoracoscopic surgery, where it's keyhole surgery within the chest. And nowadays, at least in NUH, what we do is we perform what we call single port surgery, just uniportal surgery. We make a small cut, about 3 to 4 centimeters. We go between the ribs. We put something called a retractor in there to keep the space nice and wide open. We stand here. We have a team of doctors and our nurses, and we use the camera and we look at the TV. It's like playing a video game. I always tell people,
Okay.
you look at the TV, but your hands are moving below there, and you dissect and you remove. So these are how our instruments go through, and you remove that certain part of the lung, the disease part of the lung that requires to come out, and eventually
Okay.
the patient, instead of having a scar literally from the back to the front, now you only have a small 4 centimeter cut over there. And the many approaches to the chest, people now talk about what we call subxiphoid approach, where instead of going from the side, you go from the front and you make a small cut in front, right under your breastbone over here. And
Mhm.
nowadays, in NUH, at least we started doing robotic surgery, and we use the robot basically to. I mean, the robot doesn't perform the surgery. We use the robotic hands, and the surgeon
Mhm.
here, we sit at the console, and then we perform surgery on the patient using the robotic hands, and that
Okay.
assists us for a little bit more finer dissection sometimes.
So,
So all
doctor,
in all, yeah,
sorry. So, if my son now start to play all these video games and these virtual games, I shouldn't
yeah.
stop him. I don't know because
I see the hand-eye coordination is
yeah.
amazing even the younger surgeons now when you see them operate. I mean,
Okay.
their hand-eye coordination is brilliant. It's really
Wow. So
good.
their cognitive skills are so well trained because of what they have been doing in the past decade. So that actually helped in their profession.
Absolutely, absolutely, and that's what it is. You see, we
Okay.
have to move with technology, right? I mean, if video games and stuff, they improve the hand-eye coordination. Even in surgery, we're trying to mimic what the rest of the world does. You see, so we're trying
Mhm,
to do
mhm,
that, and we find out that the outcomes are better. Patient recovery is much better. Last time
mhm,
they used to do lung surgery, and patient will stay in the hospital for maybe 2 3 weeks. Nowadays, they go home after 2 3 days. If everything goes
mhm.
well. So times are changing. Yeah.
Okay.
So what I wanted to show you is this. The big cuts from before has come into
Okay.
a small cut at the side. You see,
Okay.
so that's what we do. So basically, well, that's my slideshow, uh, and I just wanted to hold on. Let me just click save. Yeah,
Right. Thank you, doctor.
and I thought I wanted to open the floor to everybody else and yourself, and let's kick off this talk.
Thank you so much for that very quick and nice presentation that you did. But of course, doctor, before we even engage the gears, and I got a couple of questions as well. I think about 2 years back, I lost my dad. We lost our dad because he was a smoker, and he stopped smoking for almost about a decade or so. But it all started up with a single cough, and then it was very irritating. It's not as it's huge or disturbance, but he decided to go, like how we have a fever or body temperature, we want to go and see a doctor, a GP. And somehow or other they say that, what, it's not good, you go to a specialist. And then they did a full test and a CT scan as well. And then they did even more further tests to identify whether that particular is it cancer. And eventually it is. And all we know that it was straight away a stage 3, and he has just 2 months to live on. So it can be very dangerous, especially it's like a seems like a silent killer. Can we call it as a silent killer?
Vance, firstly, my condolences to you and your family. But you're absolutely right. Cancer is the silent killer because when you start getting symptoms, it actually can be late already. So this is why I tell many patients that, uh, you know, uh, we should get ourselves checked on a regular basis. And you see this a lot. People who do screening, do an X-ray, and they completely well. They always come to me and say, "Doctor, I have nothing. I'm well. I've not no issue. How come this is here? And you use the exact, that's the perfect sentence to say, cancer is a silent killer.
Mhm,
When you
mhm.
start getting symptoms, then it's unfortunately not for everybody, but unfortunately it's the late stage.
And the whole process itself, I mean, even though I'm not in the health industry exactly in the fitness, but I do a lot of projects right now and associate with them. But I did see a deterioration happens, body weight start to lose on. He started to lose body weight. His appetite started to drop. He tend to become very moody. And as time goes by, his oxygen levels tend to drop it because as the oncologists say that he had just like 2 months, and it's very accurate because as the body deteriorates and the cancer becomes multiplying, and we eventually saw him just without oxygen, and he passed on. So it's very scary, doctor. But if someone like a healthy individual, is there something like, I do a yearly checkup, blood check, I want to check my HB1AC, hemoglobin, all kinds of stuff. But is there something like, I want to go and check my markers for my cancers? I want to check, make sure that is it a yearly, or there don't seem to be a years like, you go to check for doctor, for cancers. Is
Yeah.
there a yeah?
So I let me speak specifically for lung cancer, I guess. So unfortunately, there's no blood test that can pick it up. I think for colon cancer, for ovarian cancer, there's certain tumor markers. They may be sensitive, but then they're not specific. They're not specific. So you can actually have a cancer, but the markers may not be raised. You see, but then there's some people who do screening, and they have this cancer marker called CEA, which is mainly for colorectal cancer, and it's mildly elevated. Then they go and do the scopes, and the scopes are all clear, and they do a CT scan, and they find out, oh, there's a lung lesion over there. All right, so the cancer markers are very non-specific. So I always tell my patients basically that, if you fall into a high risk group, screening is very important. And who are these high risk groups? Basically, it's people who are smokers, current smokers, people who are basically have a family history of cancer, people who work in a high risk industry where there's a lot of smoke or fumigation going around, um, people who, the unfortunate thing is that we there's no direct association, but with temples and all the joss sticks that they use, and especially
Mhm,
if you're exposed to that smoke a lot,
mhm, mhm,
that's very, very dangerous, because that equals to almost smoking your own cigarettes every day, even if you don't smoke. So I really am a big what's that word? I encourage people basically to do regular screening. So after you're 40 years old, an X-ray is great. You don't need to do an X-ray every year, but I
mhm,
think part of your medical checkup, most companies will get you to do one actually every 2 to 5 years at least.
mhm,
And if you do have so there's no direct evidence that screening actually prevents cancer, but screening does pick up cancer. And though the pickup rate is small, 2 to 3%, you still can save that 2 to 3% of people. So if you're a smoker, you're above the age of 42, 43 years old, I think go and do it. Nowadays we got these low dose CT screenings where they use very low radiation levels. You can do a scan. If that's clear, all and good. If they find a small lesion that's very, very small, you don't need to do any surgery straight away. You can observe it. We can repeat a scan. And anything that's growing, then you might as well intervene early and get it out. So I think screening is very, very important. I wanted to bring up something that a lot of people say, oh, I don't smoke, I'll be fine. And so, the Singapore statistics basically said, firstly shows that lung cancer is the second biggest killer in men in
okay.
Singapore, and is the third biggest killer in females, right? And these numbers are alarming. You're looking at about maybe 7 to 8,000 new patients being diagnosed in Singapore, and the smoking rate in Singapore is very low. We only have about 10 to 12% of people who smoke in Singapore.
That's right.
And so you're wondering, how is this possible? Why are females getting it too? And we've identified a group of patients basically, which is female, Asian, in their ranges of 40 to 65, even 70, who are what we call never smokers. Never smokers are
Never
not
smoke.
like, basically, they've never touched a single cigarette their whole life. They're not like they quit smoking or they are current smokers. They're never smokers and they get lung cancer. And you're wondering, why is this happening? So with all the research that's been going on, we've detected a gene called EGFR mutation, and it's a mutation of the gene within the body that actually stimulates this cancer, and makes it happen. So it's very important to get screened, get checked, and if the cancer is early detected, even if it's stage one, once you resect it, you don't need to go for any chemotherapy. If it's a higher stage, so stage one, there's many stages, 1A, 2, 3, and there's a stage 1B where then we can recommend you to see the oncologist to take a like an oral chemotherapy. But after surgery for stage 2, stage 3, then you definitely need to have added chemotherapy because it shows that it improves survival a lot. But I really wanted to highlight the importance of screening for patients. And there was a study done just published this year by
Okay.
Taiwan. It's called the Talent Study. I think people, you can just Google Talent Lung Cancer Study, and they looked at never smokers. So they screened about 12,000 people who never smoked,
Mhm.
and then they part of the secondary they looked at people who had a family history of cancer and things like that. And they
Okay.
found that out of 12,000 people, 2% of this group
Mhm.
had cancer, right? So, and people say, yeah, 2%, it's a small number, but what if that 2% is you? That 2% becomes 100% for you, right?
Yeah.
So it's important to get checked. I think that's very important.
Thank you for doctor for highlighting that
Yeah.
screening is very important that you have highlighted, and hope viewers are watching that as well and understand that very important. Most of the time it's like that. It will never happen to me. It's never me. And then what happens if reality really kicks in you hard in the butt, and then
Yeah.
start to worry. But doctor, I got a next question myself, but I think Chris have that question itself for you. Like before I pull on that thing here to address a question. But I think there must be something happening, right? We call it physically or mentally or psychologically, whatever it can be. But our cells are turning against us for some reason. Like what you said, the mutation is happening. Um, is it could be the stress that we're all facing? Because stress could be also an factor, but like we said, is there like a study saying that stress is one of a
Well,
possibility that can,
for heart disease, yeah, that's without a doubt
yeah,
a proven fact. For
yeah,
cancer, unfortunately, I at least on top of my head, I can't pull out any data that I know of.
yeah,
But let me just tell you a correlation between smoking and the type of cancer. So
okay,
back in the days, people used to smoke unfiltered cigarettes,
okay,
and they used to get this type of lung cancer called squamous cell carcinoma. All right, squamous cell. And then when as people stop smoking, or I don't know whether filtered cigarettes or things that come in, the amount of squamous cell carcinoma has dropped tremendously in the world in the
hmm,
past 50 years. But the lung cancer is picking up, and you get this new cancer called, I mean, it's not a new cancer, it's just a different subtype of lung cancer called adenocarcinoma, right?
okay,
And is that associated with our diet? Is it associated with the food we eat? I know, you watch a lot of these documentaries about the plastic in the ocean, and
yeah.
the fish are eating the plastic, and we're eating the fish, and that, someone said actually in general we're eating about one piece of a credit card every week, of plastic, right?
Okay, that's fine.
So could that be related? I don't know. This is me
Yeah,
just
I mean, I'm sure all the viewers will not mind if we can
yeah.
do some transaction FOC, but it doesn't give you any FOC.
No, I don't know. I mean, this part I don't know. But yes, why are we seeing more cancers?
Okay.
Maybe because we're screening more also. We're picking up more. So, and patients
All
are
right,
more
Doc.
aware.
So we have a couple of questions all coming out, lining up. So I'm definitely going to take this, Chris, from
Sure.
the viewer, Chris.
Yeah.
Will there be a cure for an cancer?
Yeah. It's maybe in about 100 years from now, who knows, all right. But what I can tell you is that cancer, I feel now, when I was in medical school back in the 1998, 99, if you had stage 4 cancer, you're going to pass away in a few months, right?
Okay.
But nowadays, with the evolution of technology and the different chemotherapies or special what we call immunotherapies, where we use our own body cells to fight the
Yeah.
cancer, things that stimulate that. I've seen patients that who would have probably passed away in 6 months
Hmm.
if it was 20 years ago. Today are living for 4 or 5 years. So that's
Hmm.
almost a what's the number? If almost a 400-500% increment in life expectancy with this
Hmm.
new medications and stuff. So I believe that maybe cancer cannot be cured, but it may
Hmm.
become a chronic disease. A
Okay.
chronic disease means that means we can control it with medication. So like
Hmm.
diabetes, like you control it with medication.
Medication.
AIDS used to be if you get AIDS, it's finished. Now people live for years with AIDS, right?
Yeah.
And people get control with it. So it probably can become a chronic disease, I think.
All right. Thank you, Doctor, and thank you, Chris, for the question itself. So we have how does the one test for the okay? So we have this question. So it's a little bit this for Doctor for sure, asked by Suba G. How does one test for the gene? Is the test readily available?
So there are a lot of genetic. I think if you go to many companies right now, they have a lot of genetic testing you can do, and they can actually really, really go through your whole DNA sequence via blood test, saliva test. I think there's a certain. I'm not. I can't speak for what they need for
Mhm.
that, but specifically, if you do have a cancer and we've taken out that cancer, we can then from that cancer specimen itself we will then send it for the specific genetic test required, whether there's a ALK mutation, EGFR mutation. We look for those things within the cancer. Now if you don't have a cancer and you want to screen yourself and see what are your risks for it, then yes, I know there are companies that do this, but I cannot speak for them. I've no experience sending my patients for genetic screening, but I know they are out there. The issue is that the question always arises is that, okay, we screen, we know you're at higher risk of getting it, but what are you going to do from there? I think the famous person is Angelina Jolie, right? She knew she
Yeah.
had the breast cancer gene and she decided to do a bilateral mastectomy. But if say you find out you got an EGFR mutation in your lungs, you can't remove both your lungs, right? Right, so
Yeah.
we have to strike a balance of what we do, what we don't do. I think having a genetic test, again, I have no experience doing this, so maybe I'm not the best person to comment about this, but maybe it can help guide how you want to get yourself checked up furthermore.
Thank you, Doctor. Thank you, Suba, for the question. We have Sinaram Sarah Shamila. What is the progenesis for stage 2 lung cancer?
So the prognosis. So
Yes.
now prognosis, I guess people have looked at all the data. So you're looking at about, in all honesty, stage two. There's two types of stage 2A and 2B. In average, the survival of a patient with stage two is about 50% at 5 years. All right, but this improves with certain chemo or now with newer medication, like I was telling you about, where they after the chemo they take tablet form, and so these are the numbers that we have from our international numbers around the world. It's about
Mhm.
50%. But also understand clearly that these numbers shift, right? The data that we have that says it's 50% or 55% or 56% are numbers taken like from the year 1996 till the year 2010, 2012. And so how patients were managed even 20 years ago is very different from today. So I'm pretty sure as we evolve, we will see a change of data set. But in all I can speak for is from the data we have is about 50 to 60% survival at 5 years.
Thank you, Doctor, and thank you, Sarah, for that question. So, Doctor, we also have one more that's pertaining to Doctor as well. So can one really get cured of a lung cancer if not in a critical stage?
Absolutely. So this
Deepa.
is a very good question, Madam Deepam. So if you have a stage one lung cancer, so you got stage 1A1, 1A2, 1A3, the survival are in the 90%. So I can't, unfortunately, in medicine, we can't give you 100% cure. But what we see again from our data is that it's got really great survival. So you just do surgery, you resect it out, and then we follow you up for 5 years continuously. And usually after you hit the 5 year mark, generally you're cancer free. In NUH, we follow the patients up to 10 years with regular CT scanning once a year. And but yes, I think if you hit a number of 95%, 90% and above, you're considered cured of cancer, or at least if you roll a dice, 1 in 10, chances of it coming back, 9 out of 10 people are cured of it. Yeah, I would. I, the word cure is a very strong word, but I think the survival benefit is extremely, extremely high.
Thank you, Deepam, for that question, and thank you, doctor, again, once again.
Sorry, one more thing. There's
Yeah.
one more thing I wanted to say. There's an area called before cancer. It's called minimally invasive adenocarcinoma or adenocarcinoma in situ. These are very, very like really early stages before it really mutates to a proper cancer. Now, these things, if you remove it, it can be almost curative. So yes. So before it evolves to a full blown adeno, that means it's not even stage 1 yet. It's labeled as TMIA. It's called. So yeah.
Thank you, Deepam. So Deepam has sent special thanks. Thank you, and Sarah as well. Thank you, Sarah, for telling that's a detailed explanation. So we have a few more questions, Doc. So this is by Justin. Just to double confirm, yeah, Justin. So I think that question is basically directed to you. So, hi, doctor. How you be able to see situations emotionally cancer day in day out? So I think he's probably is asking your mental state, or maybe perhaps the emotional part. Well, I mean, you can't be emotionally right, but
Well,
how?
Justin, that's a great question. I think, and this is probably relevant to every doctor or from an oncologist. The point is that we don't get emotionally involved with our patients, but we actually still do. A lot of these patients, I've been attending to them for 5, 6, 7 years. I've seen them. We've both. I've lost. They've seen me with hair and they've seen me without hair. So it's we when we're there to do our job. It's going to be a very professional relationship between both of us. My job is to treat you, to make sure you're emotionally strong. And what's important is it's a two-way process. You have to have trust in me as your surgeon, and for me to do my job, I need you to trust me, and then we work together. And when that bond happens, then we do have an emotional bond with each other, and it's a professional emotional bond. But with time, I've become friends with some of my patients in the sense that I mean, I'm not calling them out. We're not going out for dinners and stuff. But what we're doing is when we meet in the clinic, even when they give me a call, they talk to me, they want to tell me something, I'm there for them. And yeah, sometimes it's sad to see that some patients that you try to save, and after a few years they don't make it or they pass on. That's emotional, and it's sad. Yeah, it does happen. So we're all human, right? At the end of the day.
But I think, doctor, I think um, like I want to mention this the third time. Nurses, especially, and doctors, I think it is not a job. I think it must be coming from that that
Yeah.
hardship.
I
Because
actually don't. I tell people I don't go to work actually every day. I
okay,
don't go to work. I like. I don't know if you call it a job, but I don't go to work. I go to something I like to do. Half my job is actually talking to people. So
so
yeah,
so whoever the creator is has done a fantastic job because he can't be everywhere. So
yeah.
he created you guys and nurses, especially nurses as well, because their job also is very challenging at time to
Nurses
time.
are amazing. I think they are really the frontliners in what we do. At the end of the day, the doctors see the patient. We may put on, people say put on the cape, but actually the people really wearing the cape are the nurses. They are the ones managing the patient right after, from before surgery. They're seeing them. They're asking, "How are you?" They're telling me, "Don't worry." They're telling the patient, "Don't worry. We'll take you in." They get into the operating theater. There's other nurses there managing them. When they wake up, the nurses are there to look at them. Don't worry, you're fine. Your vitals are okay. So nurses, and then up to the ward, helping them, eat, helping them walk. The physiotherapists do that too. having to go to the washroom, they're angels. I think they deserve a lot more credit than anybody
So
else.
for that, doctor, we are going to give you a round of applause now.
Yeah.
Thank you, doctor. Thank you so much for that. We have a couple of questions, and also we have a couple of people sending their regards to you. Yes, that's Dr. Harish, the popular guy right now. We also have Sakti, a very good buddy of mine as well. He also has said that thank you for sharing, Dr. Harish. Awesome sessions. And we have a question from Christina Vijayan. If a person who usually has a higher white blood cells, is it highly possible to have a cancer in the future?
No. So, are you referring to leukemia? Is she referring to leukemia? And it depends on what the level of white. So, white blood cells are what we call our soldiers in our body, right? So, when white blood cells increase, they are fighting something generally. So, most of the time, it's infection. So, they're fighting some sort of infection. That's why the white cell goes up. And that's why when we're treating any patients, we trend the white cell. But white cells can go up or can completely deplete in different types of cancers too, or blood-borne cancers or leukemias and things like that. So that can be an issue. Is it possible to have other cancers associated with high blood cells? Um, in general, probably no, unless there's something else. So generally, you tend to worry a lot when the high blood cells are very high. You tend to worry more of a blood-borne kind of a cancer.
All right. So hope that has answered you, Christina. Thank you, Christina, for that question. I'm also going to bring in one more question, doctor. So just give me a second. I'm going to get that thing up here. So da da da, and there we go. Okay. So just give me that final. Um, we have Victoria. All right. So Victoria has asked, is there any symptoms? Does cancer have symptoms?
Again, like I said, most of the time it's a stupid silent killer, isn't it? But having said that, you still can have symptoms with early stage cancer. So basically, in life, there's no yes and no answer. That's the unfortunate thing. So you do have symptoms. Some people can have. If let's focus on lung because that's what we're talking about here. So if it's a lung cancer, some people can get a cough, like unfortunately like your dad had, and unfortunately it's late stage. But we also see many patients who have a cough and it's early stage because it irritates certain airways. They can have cough with blood sometimes.
Mhm.
They can have difficulty in breathing. They may have a bit of chest pain. So it can be many, many things. But a lot of times, the early stage cancers don't show itself at all. And if it does, that's great because it's your body telling you that something's going on. So you should get yourself checked. A lot of times we ignore this thing, we say, nothing,
Mm.
Uh, we always think we're young. That's the unfortunate thing, right? But yeah, things catch up to us now. We're not so invincible anymore.
Well said, doctor. I mean, you can be young at the heart, but as the body is aging, we need
Yeah,
to make sure that we send for servicing and get the right
absolutely,
specialist to attend to it. Yeah,
absolutely.
the human body is just like a car, doctor.
Yeah.
Doc, we have another one more question that's directly from LinkedIn because right now Kopi Events is also live in YouTube, Facebook, and LinkedIn, and few more
Wow.
other platforms are just on approval right now.
Mhm.
So I'm going to pull this up. So this is David Neto. Dr. Harish, I was your junior from Malacca, Manipal. What are the subtle signs of lung cancer that we can detect early to diagnose lung cancer? Because, as you know, lung cancer is usually detected late at 3 or 4.
Hi, David, Dr. David. How are you?
Doctor there. Hi, doctor.
uh, yeah, Manipal Melaka was my medical school I went to in Malaysia before I
Okay.
moved to Singapore. So, what are the subtle signs of lung cancer? The signs basically, again, like I mentioned to you, so symptoms is what patients actually experience, and signs are what. So if everyone to understand, signs, symptoms is what the patient experience. Signs are what doctors can pick up. All right. So if you put a stethoscope to the lung and you take deep breaths, you'll hear breath sounds. And if you hear the breath sounds become reduced, then you're worried that it can be blocked. Either you have a pneumonia, you have water in the lungs, things like that. The unfortunate thing, like with early stage lung cancer, it's a small ball there, and this small ball doesn't affect anything. Everything goes on like normal. So unless you're so specific that you put it right over the ball, I don't think you're gonna have any signs that you're gonna pick up. So that's why with lung cancer, we always have this issue: it's screening, screening, screening. It's X-rays and CT scans, and that's the only. Every time you suspect something, do a CT scan. If it's in a high risk group, I think you should get if it's a high risk group smoker and stuff, you must get a CT scan for the patient. So suspicion for a doctor, your suspicion index must be very high when it's this group of people.
Thank you, Dr. David and Dr. Harish, for that answering that particular questions directly from Dr. David. So that's all for the questions today. So, Doctor, it was an amazing 47 minutes. So we have covered all the PowerPoint. We have answered a couple of questions from the viewers. So now it's time for Kopi with Vance. So,
Right.
Doctor, what is your advice for future doctors or students, medical students who are watching this? And like I said, if you ask me to be a doctor, I think I probably can't, because when I look at all these particular machines, I'll be go blank, because it's a different emotional, right? But like I said, you need to have iron in you to do this. So, what will your advice be for the young doctors, or even for students who want to be a future doctors? What is your advice will be?
Okay, the medical career, a lot of people say that, oh, the medical career, doctors are very tough. It's a very difficult field to get into and stuff. But I think the medical career is one of the best professions to be in. Um, at the end of the day, whatever you're doing, you are trying your best to help somebody. A lot of times you may find you get frustrated, and frustration is in any field you get into, whether it's a banking field, whether you're a lawyer. I'm sure as a video host, as a PT, there's always frustrations. You can never be right, and you can never please everybody in the world. Yeah, you can be the best doctor, nice person in the world, someone will still not like you. What's my advice to these doctors is that, if you want to get into the field of medicine, do not have expectations. If you have the expectation that you are going to be respected by everybody around you, you're gonna walk on pedestal. If you feel that you're gonna make a lot of money doing it, then don't get into it. If you have no expectations and you have a clear heart and you want to do it, you want to help people, or you want to improve technology or improve medical technology, then this is a great field to get into, and do it, because I encourage people. I think medicine, medical field in general, nursing, anything to do, is a wonderful field to get into. Just have your head straight.
Thank you, Doctor. Thank you for that. Thank you, Doctor. Before we even come to this live chat in streaming at Kopi Events, we were having a little talk regarding about your schedule, right? You work on a very, very hectic schedule, especially with associating with this cancer, and you're trying to work on this. But how do you? I mean, each surgery, how long does it takes? Because you need to
So,
be.
great question. It's not that long. You know, if you're doing heart operations, bypass surgery, that can be long, can be 4, 6, 7, 8, 9 hours. Most of the time, when we do lung cancer surgery, is about 2 to 3 hours each time. It can extend to 4 to 5 hours. I've done surgeries for 12, 13 hours. So usually we line up about 2 to 3 patients per session when we operate the whole day. So we're there actually from 8 to 5 or 8 to 6. So you are performing surgery, you're doing it for 2 to 3 hours, but really you don't feel the time go. The time just flows. It's like, you go into a cinema, you watch Avengers movie, it's 2.5 hours. And when you finish, you're like, wow, it's 2.5 hours. It's the same thing, because you're so focused. You're performing the surgery, your hands are moving, your eyes are focused, your brain's working. Time just flies, so you don't feel it.
Thank you so much, Doctor. I mean, it's definitely a valuable session today at Kopi Units. I know this topic can go into a lot of more, right? I mean, we are just talking about the respiratory system, the lung, but of course, there is a lot of other cancers that we can talk about the whole day, but unfortunately we don't have. With having that, saying that, and doctor, your advice to all the viewers, you have given your advices to the young doctors who want to be, and for the viewers who are watching this, what will be the health advice or tip that you will give it to them?
Well, I'm not gonna get into telling people to change whatever habit they have, because that's, I think, in their own mind. But for me, I think you know it yourself. If you fall into a high risk category, or even if you don't fall into a high risk category, I feel that you should do some sort of screening on a regular basis after the age of 40 years old, whether it's an X-ray, blood test, or CT scan. You don't need to do it every year, but you can spread it out over once in 4 to 5 years, and I think that's very important.
Thank you, doctor. I mean, I know you are a busy man. You know, to get you in Kopi events, it almost take 2 months, and I know how your schedule was because all the communication that we had. I know how hectic it can be. My hats off for doctors who are out there saving humans' life. Apart from the creator, because after a creator, they always look at the doctor. Doctor, please help. So amazing, amazing, amazing thing, and hats off to the nurses and also to your profession as a doctor. Thank you, Dr.
Thank you,
Harish.
Vance. Thank you, and thank you. Have a good night, everybody.
Thank you, doctor. We will catch up
All
very
right,
soon for real coffee. Okay.
real
By
coffee.
the way,
Got it.
do you drink coffee? Right?
I love coffee. I drink coffee only black.
It's okay, doctor. As long as Kopi with Vans, let's do it.
All right. Okay. Cool.
All right, doctor. We'll catch
All right.
up. We will stay tuned. All right. Thank
All right.
you.
Take care.
I'll
Bye,
sign you off
Vance.
right now.
Bye.
Yeah.
Bye.
Thank you. All right, folks. So that it was Dr. Harish with us for the past. Let me see how long was it? 53 minutes. That's right. We talk about cancers, and we all can also talk about screenings. We can also talk about smokings, and so on and so forth. But I think when it comes to the tip of Vans, I call it the Kopi Vans tip. I think it's very crucial that the one thing that we need to always respect and be super kind, and nothing about curry flavors and all that, but you got to take care of thing that you live in. We tend to keep our houses clean, we tend to keep things around nicely, but sometimes we don't tend to take care of the body that we live in, because that's the only place that we live in. So if there's any signs and symptoms, if there's pain, you know yourself, right? And it's not only just a normal flu or cough or even a pain in your ankles. I think it is better to get checked up. All right. If the pain symptoms or sign and symptoms last for more than 12 or 48 hours, I think it need to be addressed. Not just to keeping it for a period of time, and it can lead to even more serious issues. And that's what exactly I give advisors or tips to all my friends and families and clients. So if there's an issue, I think that has been needed to dive into the root of the problem and solve it there itself before it manifests to even a bigger thing. So take care of our body, be healthy, be fit, and at all times be yourself. All right. So this is another segment with Kopi Events, and I'll be catching you again Wednesday at 9 p.m. for another topic, which is we have our speakers already lined up for another exciting topic that is going to come in. The month of September, it's just purely about health. We're going to bring in lots of more doctors and professionals like Dr. Harish. He came in, spend his valuable 47 minutes, because that 47 minute he should be resting, spending time with his family. But that's the kind of a doctor that I was saying, right? He doesn't even feel like going to work. It's not even a work. It is him, right? So it's great passion to see, how much you want to serve the community as a profession in itself. I think that's why I said earlier that nurses and doctors are the angels. They are just covering all the wings at the back of their coat. If it's so, that doesn't mean that you go and pull up the the coat of a doctor and say, "Where's your wings?" Right? I'll catch you again. That is next week, Wednesday, for a different topic. For right now, Kopi with Vance. Catch ya.